Dominic, we were just talking, has set up an NGO to pursue quality monitoring in healthcare. I think private healthcare in particular, but you will tell us. You will correct me if I'm wrong. And Dominic is a UCSF and national and global expert and leader on the role of the private sector in healthcare. So he didn't have to come far to talk with us, but we're really glad that he's in these parts and willing to every year to come and teach this class. And the way we're going to set it up today is you're going to talk for 15 minutes, we're going to take a short break, and then you will finish up at the end with another 15 minutes. So thank you, Dominic, again for being a stalwart in this course.
A great pleasure. Wow. And on that build-up, this threat of pop quizzes, by the way, this is a new pleasure that you have. I don't think that everybody else had to suffer through that. But I assume if you're not putting a pool together with bets on whether or not you will have the quiz or not, you're sort of missing an opportunity there. I did ask whether Jim thought that you would all read the papers, and he said yes, and now I understand why. So I'm very glad for that for me, selfishly. And I wanted to, and for the presentations that you prepared, I'm looking forward to. And I wanted to talk about the private sector, which basically in the world there are two perspectives on private healthcare delivery in low and middle income countries. The first, represented here by Oxfam, is that the private sector must be a bad thing for the provision of healthcare. That private for-profit, profit-taking in the provision of a social good must be inherently a dangerous and non-socially optimal thing and therefore should not be done. And that an ideal healthcare system, like an ideal education system, should model the idealized version of the NHS, of the British healthcare system, where it's government funded, freely available, on demand for all. And we'll hear about UHC. There's a trend towards that globally. The alternative, unsurprisingly put forward by the World Bank, and this report came from the International Finance Corporation, which is a subsidiary of the World Bank Group, is that the private sector is good. And their argument essentially is every capitalist argument that you've heard, which is that monopolies are inefficient. And that's true of private sector monopolies, that's true of government monopolies, that anyone who does not have to compete and improve becomes fat and lazy. And there's that is simply sort of inherent in the nature of not being forced to do better. And therefore, the private sector is more dynamic, makes new investments, takes risks, goes to serve populations that wouldn't be served by an institution that doesn't have to, that may have a mandate to, but nonetheless has no market force pushing them to do, and markets are good, and the private sector can be regulated to assure good. So I would argue that one might reasonably in most middle-income countries and low-income countries set aside the debate simply because the private sector is there and unlikely to go away anytime soon. So this is the percent of all physicians in India who were employed by the government, beginning at independence and going through the end of 2008. And free access to healthcare is enshrined in the Constitution of India. And the government has pretty consistently employed between 20 and 30% of all doctors in the country from the time of independence, and that hasn't really changed. So with lots of national initiatives to reduce the importance of the private sector and a strong desire at many different times in the history of the Indian National Health Service to reduce or eliminate private healthcare provision. It's difficult to move a giant supertanker with a policy action unless you have all the money in the world. So Cuba managed it, took a revolution. Canada managed it. It took a 2-year doctors' strike in Saskatchewan in 1950s, at a time when not many other things were going on with financing and there was money available. And the UK managed it after having nationalized most health care during World War II. And Cambodia managed it because of the extremes of Pol Pot and the follow-up with the UN-led management of the healthcare system. But absent some major cataclysm, countries don't go from having having predominantly private provision of healthcare to having predominantly governmental provision of healthcare. The idealized decision that you could change policy and expect the market to follow, or the government to follow, happens only when there is something dramatic and usually quite negative at a national level in terms of upheavals. So most health policy and planning is based on this idealized model: 3 stages of healthcare, right? Tertiary, primary care, secondary care. And you have your nuclear family that goes to the local health post, and if necessary, they get referred upwards to the district or provincial health post, depending on the country, and from there to a state health institution, perhaps a specialized hospital. And that has been, that's been the way that people have talked about health systems since the 1940s. And in fact, it comes, or it dovetails nicely with this image from UNICEF from the 1960s, where you can close your eyes just a little bit and imagine a sweet village on the veldt in Africa with a cluster of huts surrounding the health station that everybody goes to when they need immunizations or get sick. The trouble is that while this may possibly have been true in the 1960s, it's been a long, long time since the world looked like this. And so this is one village in Madhya Pradesh that was studied by a colleague of mine at the World Bank named Jishnu Das. And this village, relatively small, 450 households, 1 government health post, and a small number of informal providers. And so you think, well, not very different from that UNICEF image in the 60s. The trouble is that this village, reasonably typical for rural Madhya Pradesh, is 2 miles away from a much larger village with 12,000 people. Again, 1 health post, a bigger one, 11 private MBBS doctors with private clinics, and a large number, about 40, different kinds of private pharmacies and private traditional Ayurvedic or rural medical practitioners practicing, giving a range of different types of healthcare. And so the people in that first village don't actually stay there, because if you go 2 miles, it's a buyer's market. There are drug sellers, pharmacies that are more or less regulated, a larger health outpost, and many doctors ready to help you with whatever ails you. And so everybody goes 2 miles. And you would be crazy not to. 2 miles is not very far anywhere in the world if you're sick. And so that's one example from India, but I think it is widely generalizable. And we're not in this 1960s UNICEF world anymore, almost anywhere. We're in a world like this. And what that means is that when people get sick, their care seeking does not go in a perfectly organized tertiary escalation of need, only working through referrals. People really go wherever they feel they're going to get the best care, depending on their own financial capacity to pay for care, ability to take time off of work, to travel, and their perspective of need. People travel farther and have a higher propensity to avoid local healthcare providers when their children are sick than when adults are sick. Higher priority on curing sick children. Often in many parts of the world, they will travel farther and spend more money when there are male children who are sick. And they'll go to pharmacies first, people for many illnesses, or to private doctors. They'll go directly to tertiary hospitals for deliveries in many instances. It's been well studied in Africa and Asia. And so the relationship between all of these different healthcare providers who make up the health system becomes hugely more complex than if it were a linear relationship in perfect hierarchy. And the forces that organize how they interact with one another through referrals, through collaborations, through getting information for updates on best practices, on new medicines, on accessibility for reimbursement through national health insurance. All of that is dictated by sort of a range of complex market forces which are often poorly regulated by governments, but which become hugely important because the private sector really isn't a parallel sector to the governmental sector. There's constant interaction because it's the same providers who go back and forth, because the referrals happen in both directions. In many places there are no drugs in low-level government facilities, so you have to go outside to buy drugs from a private provider. No private provider in a clinic or hospital wants patients to die on them, so very ill patients get referred to government hospitals always. Those kinds of relationships are constant, and they happen well or they happen poorly depending on the regulatory maybe capacity or attention of governments. So that I think is there. We could stop now. That's really the take home. So just to give you one last summary about the global evidence for the things that I was illustrating from Madhya Pradesh. This is from DHS data over the past 45 years, and you can see the source of healthcare in South Asia. It's about 80% of all healthcare is purchased from some kind of private provider, and it's above 60% in Southeast Asia and 50% in Sub-Saharan Africa. So what that means, though, differs by who's buying the healthcare. So if it's 50% public and private in Sub-Saharan Africa, you really have to wonder, what is it according to wealth level? Is it just rich people opting out? And it isn't. It's actually about 50% regardless of the wealth quintile. But there are significant differences in what private means if one is rich or poor. So poor people in Sub-Saharan Africa go to the private sector, and that means primarily shops and pharmacies. So it's drug purchases by and large. And if you're very rich, this is the wealthiest quintile illustrated, going to the private sector means hospitals, pharmacies, and doctors, formal sector pharmacies. So private sector already is a bit of a simplistic aggregation to talk about half of the healthcare delivery system in a country. You can see similar differences by delivery services, so this is actually a bit out of date. But in Sub-Saharan Africa, the government sector in gray provides delivery services for half of all rich people and about 1/5 of people in the lowest two wealth quintiles. And the majority of people who are poor give birth at home, at their own home or at a parent's home or someone else's house. And this is largely due to urbanization, because if you live in a city, you are almost definitionally in Sub-Saharan Africa in the wealthiest 20% of the national distribution. And there's a higher concentration of facilities of any kind. So hospitals are in cities. If you're going to give birth in a hospital, you have a better chance of doing that if you live in a city, and this is why government services are more used by urban populations, by rich populations, than poor. In South Asia, This has changed dramatically since this data was available just because of a subsidy program in India. But from about 8 years ago, it was more or less true, the difference being that for the richest quintile, the private sector was very important, much more important than in Africa. Southeast Asia similarly, in the Philippines and Indonesia, about 1/2 of all hospitals are religious hospitals in both countries. So that's that light pink there. And in Latin America, it's the government is much more equitable in providing access across wealth levels, at least in the countries that are studied by DHS. So you might ask, I don't know if you would, but you might ask if the reason for using the private sector so much is simply because there's more of it, right? And that would be a reasonable assumption. So this is one district, again, in Madhya Pradesh, and the red dots are government health posts, and the blue dots are private outlets for health services of all kinds. But you can see it's mostly blue. The red fades into the background. So the private delivery points are greater, usage is high, and usage is, at least in upper middle income countries, increasing. In other words, people are buying out of private provision slightly over time, it would appear. Buying out of public provision, doing direct purchasing of private healthcare services. And that may change with the expansion of national health insurance programs, which really began about 10 years ago, so about the time this data was being collected. So that will be interesting to see in the next few years if that's true. And part of all of this comes, unsurprisingly, back to financing, that people who have to pay for care, regardless of whether it's public or private, go for care that is responsive and nearby, which would be private, because remember the blue map. And that we know that changes as countries get richer. That poor countries, low-income countries, have a finance system for healthcare that is predominantly private out-of-pocket, that governments expand their spending on healthcare faster than overall GDP growth. So the percent of healthcare in government budgets expands dramatically faster than government budgets. And that private insurance systems also expand pretty rapidly after countries hit about $3,000 per capita per year. And so there is this shift where out-of-pocket spending never disappears, but it's flat at about 2% of GDP across all countries. And you can see that except for the US and Mexico and South Korea, all other OECD countries, all other rich countries, are light green, meaning that the government is the major funder of healthcare, and for low and middle income countries, private and out-of-pocket is much more significant. So those three countries are outliers for OECD countries. So public financing, however, does not mean that the provision is public. There are many ways to skin that cat of assuring health service availability. And in fact, the majority of OECD countries, OECD, you know what it is, the rich countries in the world, the majority of them have primary care delivery systems that are primarily private, contracted by governments. This is the same thing just with the countries listed. And similarly, they have a large percentage of privately owned beds. You can find both. You can find countries where nearly all beds are private, Korea, the Netherlands, Japan. You can find many countries in the middle, and you can find rich countries like the UK and Denmark and Sweden where most beds are governmental. But I don't think anyone would argue that healthcare availability or quality is better in the UK than in Germany. They look very similar. Depends on how you measure it, but there's a lot of survey data that suggests satisfaction, access, treatment rates, hospitalization duration in hospitals, all the same. So all that to say that the idea, one has to, in developing countries, deal with a large private delivery system and a growing importance of government attention to that. There are a number of interventions that can be seen as leverage points to provide information on how best to work with the private sector. But probably this idea of having an entirely private delivery system or an entirely public delivery system is not anything that's really in the future of most low and middle income countries. So a mixed system like one sees in most of Europe is, I think, likely to continue in most countries. And because of that, learning about ways to work with the private sector becomes more important and more interesting. This is at least one way to summarize the different types of system failures that exist within healthcare systems where there's a predominantly private component. There are quality challenges, safety issues. There is a provision of unnecessary care, which of course we know happens in the US and in other wealthy countries as well. Certainly happens in developing countries. Overprescription of antibiotics, prescription of antimalarials to people who don't have malaria. Many kinds of treatments which are incentivized sales of services or commodities that don't benefit the patient. And there are wider social impacts to that kind of overconsumption or sale and consumption of unnecessary or inappropriate medicines, including drug resistance, as was explained in the case of anti-malarial resistance in Myanmar because of the widespread use of monotherapies. And of course, there are huge inequities that access to care where one has to predominantly pay out of pocket clearly is going to create an exclusion of access to better quality, higher level care among people who are wealthier and living in urban areas. And so, at a conceptual level, the ways that one can address these inherent systematic problems with private healthcare provision would be first to prohibit or constrain private provision, reduce the scale of private healthcare within the overall system, assuring that government-regulated, managed government providers are the main source of healthcare. Encouraging or leveraging existing private providers as a way of incentivizing better behavior, better practices, increasing accessibility, or through purchase agreements where essentially the private provision sector becomes co-opted to deliver services that are subsidized fully or partially by government, and therefore address some of the issues around equity while hopefully setting standards of quality of care which can be enforced as part of a purchase agreement. And so the tools to do any of those broadly fall into the kinds of tools that you all illustrated. PPM DOTS might be one of the exceptions because it's a global initiative. We didn't talk about regulatory systems or accreditation this year, but we have in the past. But there are, when one thinks about regulation, the most common types of regulation that are used in healthcare, certainly in developing countries, but maybe all over the world, are around statutory controls. Who is able to provide care, provide diagnosis, treatment, sell drugs? You have to have received certain levels of training. You have to be registered with the government. You have to pass perhaps national or annual or biannual certification trainings. You have to work within a facility that's also registered. You have to pay taxes, all those kinds of regulatory controls. And if you don't, you'll be fined, put in jail, all those good things. It's also quite common that professional organizations play a significant role in self-regulation. So the American Medical Association actually is, in the US, the institution that defines who is able to call themselves a doctor, who's able to practice medicine. Similar in the UK, similar in most OECD countries, and similar, to be honest, to greater or lesser extents in middle-income countries as well. So regulation, there tends to be, in almost all settings, overlapping spheres of influence for regulation of the private sector. There are trade regulations, so you have to pay taxes and you have to have a registered facility. There are organizational, institutional regulations if you're not associated with the AMA. If you're not a registered physician with the AMA and you're paying up-to-date dues and you don't do your CMEs, your continual medical education, you can't practice as a physician in the US. There are, of course, certification requirements that are governmental, state and national in the US, similar in many countries. And then often there are third-party accreditation programs. So if you know the Joint Commission in the US or the King's Fund in the UK, there are similar hospital accreditation boards which set standards, a bit like the ISO, the International Standards Organization, for different types of hospitals and medical facilities, blood banks, outpatient clinics, inpatient surgical wards. They set graded standards, a bit like the system of stars for a hotel that you would go to, and reimbursements are conditional upon those. So as a hospital in the US, you can't get reimbursed for Medicare and Medicaid unless you are JCI accredited. JCI is an independent, non-governmental entity, but it offers accreditation and funding is conditional upon that. So that kind of overlapping regulatory environment is the norm, and that's at the core of how one constrains improper practices in private providers. The encouragement, well, this would be the leveraging, right? And that's really at the heart of many of the examples that came, right? The idea that you would look at subsidizing different markets for commodities or for services, and thereby get providers or shopkeepers to sell services or products that might not be a priority, preventive services in general, for clients or consumers or for the providers themselves, but with a subsidy and support could become important enough that the private sector would then take those up and offer diabetes treatment, tuberculosis management, or family planning services. Or one can purchase directly, either through vouchers and output-based aid, or through contracts, or in fact through social health insurance reimbursement services. So the expansion I mentioned earlier of universal health coverage as a global theme, it's one of the SDGs, is largely predicated on an expansion of social health insurance schemes, which is, I would say, becoming the norm in many middle-income countries. And so that is, in effect, a form of purchasing services, the reimbursement at a set rate for services delivered through public or private facilities. Yes?
Just so I'm clear, so you said that the SDGs are encouraging what type of system? The public, private, or the both? I'm just trying to
So the
understand
SDGs have, there is an SDG measure for the percent of the population covered by universal health coverage. Well, sorry, the percent of the measure progress towards UHC.
Right.
And universal health coverage is public-private agnostic.
Right.
But the way that it's been supported in 27 countries that the bank has been supporting this is through social health insurance expansion that purchases services both from public and private providers.
Okay.
Primarily public, the expansion of purchasing from the private sector comes with all sorts of problems that means that it gets talked about and the implementation is much slower in most places. But that idea of having centralized government overseen, not necessarily government managed, but usually government managed or overseen, funding, which would purchase, which is separated from provision, and therefore has an incentive to purchase from whoever delivers the service at the best quality, at the best price, that's expanding. Is it transforming the world? No, but it's definitely there is a trend in that direction. There are some challenges with these different options. So one is that prohibition doesn't really work. So the world is littered with examples of countries that have outlawed certain practices. Cambodia famously created a whole police force to enforce the restriction on private drug sellers in about 2004, and then quietly disbanded it in 2008 or 9 because it had no effect. It is very hard without a strong regulatory system to completely ban the provision of a service or the sale of commodities that serves a niche that isn't being served otherwise and that's widespread. It's not that it's impossible, but it's very rare. And there are a lot more failures than there are successes. So I think this is certainly true for abortion services. We know this in the US as an example, but it's true for informal drug sales, which no country likes, and it takes a level of regulatory infrastructure to effectively reduce informal drug sales that low-income and lower middle-income countries almost never have. So a policy alone doesn't lead to much without quite a lot of infrastructure. Constraint is also problematic, if only because, as you can see here, in Africa, only 6 out of 47 countries that were surveyed actually have an effective registry of private providers. So the idea that you can set regulatory limits is essentially impossible just from the start because there's no list on who to go and enforce those limits, set requirements. Yeah. Oh, I was afraid someone would ask. I'm afraid I don't know. I do know that, well, one is certainly South Africa, which South Africa's an outlier here. And I would imagine Zambia, because there just aren't many private providers in Zambia. And then I would have to guess about the rest. You want to know if it's Kenya. It's, yeah, it could be. Kenya has really good systems. I'd say there's a really good chance. So there are common problems in low and middle income countries, which is that enforcement is challenging. Again, South Africa is an exception. The Seychelles are an exception. Sri Lanka is clearly an exception. But by and large, enforcement of regulatory rules and restrictions for any kind of service, not just health services, are imperfect. And there isn't much evidence for policy improvements or policy changes that works for health delivery in low and middle income countries. There isn't much evidence in OECD countries. The European Union has a commission that looks at health systems and health policy that's been writing policy papers for 20 years. And there's, it's made a huge difference in understanding the evolution of health policies across the European Union, but they still go up and down because by and large, one implements a policy, let's say privatizing pharmacies in Sweden in the 80s, and then there is a reactionary effect, which is that consolidation of pharmacies because they're now private leads to higher prices and lower accessibility, and there's a change in government, and so they become nationalized. and that has problems to do with rising costs of provision and unhappy, poor service quality, and now it's somewhere in the middle. So that's well documented. It's well documented in many countries, and by and large, policies around private provision of any kind of service tends to go back and forth like that, a bit like a pendulum. And having a lot of evidence about what happened in France doesn't actually make much of a difference when policymakers in London decide what they want to do in the UK, unsurprisingly. But there's even less evidence, meaning almost none, when it comes to sub-Saharan Africa and Latin America and Asia. Self-regulation is a very good idea. There's some evidence that it works, but it's poor. And accreditation, which is the norm across all OECD countries for hospitals and for higher level services, has a lot of people who are greatly in favor of it, and it has really poor evidence of success in middle income countries. There was just a Cochrane review that was done a few years ago. So basically, regulation is a really good idea. It's certainly necessary, and we can't say how it should be done. Frustrating, but true. Which is why, as we talked about at the beginning, the NGOs are important, because NGOs offer, it's not that they're important of themselves. They're important to the hundreds of thousands or millions of people who get services from them, yes. But compared to the billions of people who need services, they're a drop in the bucket. But they're an important drop in the bucket because they offer examples of ways that one might incentivize different types of service, whether it's increased access, provision of services that weren't otherwise offered, or I guess internalization and adoption of quality standards that might not have been there before. And vouchers, social marketing, social franchising, all the things that we talked about today are really important because they give us a lot of information about how, often how not to, but certainly about how to do some of those things. And that's been very important. And those things, those ideas and examples have become internalized into national policy in many instances. And that's why this matters. The number of programs is very large. They are, none of them sustainable. They are, well, some of the social marketing. For the most part, they're not sustainable. They require external funding. And governments sometimes, but seldom, jump onto these and say, oh, that's great. Instead of funding our own service provision, we want to fund these organizations. It happens sometimes. They get integrated into national programs the way that has happened for tuberculosis, sometimes for family planning. But it happens around the edges. But the lessons, I think, are more broadly adopted than just in those services. So I think you guys summarized this evidence base well. So the strengths are, well, clearly they're attractive to donors and they're important for operating, especially around services that governments are uncomfortable providing. Tuberculosis treatment, abortion services, post-abortion care, family planning, anything having to do with sex workers. So there are a lot of things that governments simply would rather be at arm's length from dealing with. But there are many limitations to scaling up either the volume or the scope of services that would be included. And so the question is it a Band-Aid or is it a bandage? I mean, I think, well, I guess I'm arguing that they're important examples, but their importance is not the services provided, but the lessons that they provide. And that has to answer, what do you want the nature of public-private mix to be, and what should governments do to shape that future? Because for good or for ill, governments still fund and provide, in most developing countries, somewhere between 40 and 80% of healthcare services. Closer to 40, 50 in most countries. So if you were cynical, you might say, well, that's only half the services, so why does that matter? But it's a single entity, or it's something approaching a single entity providing half the services, compared to the tens of thousands of private providers, drug sellers, pharmacies, import-export agencies, et cetera, that make up the private sector. So the policy, regulatory, and decisions of any kind around provision that are made in government are the ones that matter because they affect 50%, which means the whole market changes. And of course, they have nominal and sometimes real oversight over the entire market. So it is, at the end of the day, what happens in the private sector is the result of a public sector policy decision. And that's where I think all of this leads, is that you can't ignore the importance of the private sector when you think about public policy, or else you're going to miss out 60% of the people who get health care, and maybe 70 or 80 or 90 in the case of India, percent of the people who provide health care. And that has historically happened a lot, but less and less now. So we know that the market by itself will deliver competition, but only on perceived quality, not on clinical quality or safety. Right? People will pay to be well treated, they'll pay for potted plants and ferns and a red carpet, and consumers of healthcare, just because of the information differential, are extremely ill-equipped to judge whether or not, as you said in Kenya, they're buying condoms that are going to tear or not, or whether or not they really need this bypass surgery. So that means that external agents matter a lot. And whether it's an NGO or it's a government, you need those third-party players to assure that the private sector is both safe and delivering good services that help general public health. That system has to be externally driven. And that has to be a part of policy. So, these I think are easy take-home messages. You don't need to see them here, you got them, I hope. The private sector is large, that would be the big one. And then the question for you, or the job that you have, is that when somebody else comes up here and they tell you this great thing about, you know, this new immunization program, this great TB program, I mean, I think you have to call them to task and say, if you're talking about Nigeria and 60 or 70% of healthcare is not delivered in the government sector, then how can you tell us about a success story that only affects 30% of the population? And presumably, if they're honest, there is no answer, right? You know, 30%, that's a big chunk, so let's talk about that. But the question has to keep being brought up, because someday in the future, that other 60 or 70% has to be brought into the planning and the policies that are incorporated in the thinking behind what you do in terms of service delivery for the 30%, because governments should both be delivering services to the people they treat and setting policies and standards for all the people they don't treat. End of sermon.